So good evening, and thanks Vikas and the organizing team for giving me this opportunity. I'll be talking on the management of diarrhea associated with targeted therapies in cancer. Now, diarrhea is a very common problem that we see in our patients who are being treated for cancer. And diarrhea is a very distressing symptom, and it can cause major morbidity. And at times, it can become serious and potentially life-threatening as well. Not only that, it may also result in treatment delays, resulting in diminished adherence to treatment and diminished compliance, which may finally compromise the long-term outcomes that we expect in these patients. Now, this is a table which enlists all the targeted therapies which can cause diarrhea and the incidence of diarrhea due to each of these agents. This is from a review article in 2014. Now, since that, many more drugs have been added to this list. And as of now, almost all the targeted small molecular drugs, as well as the monoclonal antibodies which target EGFR, cause diarrhea as a side effect. And the incidence is to the tune of 20 to 50% in these patients being treated with these molecules. Now, the pathophysiological mechanisms of diarrhea because of chemotherapy are very well studied, and also the pharmacogenetics that we know in patients with 5FU or irinotecan. But we don't have any robust or adequate data for patients with being treated with targeted therapy. Different classes of biological agents, as well as single agents in a specific class, may cause diarrhea because of different mechanisms. But the proposed mechanisms are as follows: secretory diarrhea, where there is an imbalance between the secretory and absorptive mechanisms of the intestinal mucosa; osmotic diarrhea, where there is an increased concentration of osmotic substances intraliminally; diarrhea because of altered gut motility; and diarrhea because of direct ischemic intestinal mucosal damage seen in agents such as sorafenib or aflibercept. Now, when you face a patient who suffers from diarrhea because of your targeted therapy, your initial assessment begins with a history to know for any contributory risk factors, as well as to determine what severity of diarrhea the patient has according to the NCI-CTC-AE grades. So dietary history, medication history, and finally a description of stools to classify the grade of diarrhea. So the diarrhea can be graded as grade 1 to grade 4, grade 5 is death. So any diarrhea where there is increase of less than 4 stools per day over baseline is grade 1. Increase of 4 to 6 stools per day is grade 2. More than 6 stools per day is grade 3. And any life-threatening complications as a result of diarrhea is grade 4. Now, this grading system does not take into account the volume and the duration of diarrhea, but nonetheless, it is important in assessing the severity of our patients suffering from diarrhea and managing them accordingly. Following the clinical history, a physical examination is important, especially targeting the abdominal region and the anorectal region, as well as for looking at vital signs which can give you clues to the complications because of diarrhea, such as dehydration, pre-renal impairment, and sepsis, etc. So it is important to look at tachycardia, hypotension, tachypnea, as well as the urine output to grade the severity of the diarrhea and its complications. Then laboratory tests and imaging studies are also important. You have to look at the complete blood count and a biochemistry screen, especially to look for any electrolyte abnormalities as a result of the diarrhea. Stool analysis, especially when you are suspecting any infective diarrhea. So look for fecal leukocytes, the toxins due to Clostridium difficile, and then a stool culture to rule out common infective organisms causing diarrhea. Imaging and endoscopic studies are rarely required, especially in patients who have a refractory diarrhea to your upfront management. Once you have carefully and clinically assessed your patient, it becomes important to classify the patient as an uncomplicated case or a complicated case, and your management depends on that. So a patient is said to have a complicated diarrhea if he presents with a severe diarrhea, that is grade 3 or 4, or if a patient has a grade 1 or 2 diarrhea with accompanying complications such as moderate to severe abdominal cramping, a grade 2 or worse nausea or vomiting, a declining performance status, signs of fever, sepsis, neutropenia, flank bleeding, or dehydration, then the patient is said to have a complicated diarrhea. As is this, any patient who presents with a mild to moderate, that is grade 1 or 2 diarrhea, with no other complicating signs or symptoms, is said to have a uncomplicated diarrhea. So your management depends on whether a patient has complicated or uncomplicated diarrhea. In patients with uncomplicated diarrhea, they are clinically stable patients and can be managed on the outpatient department. So in such patients, dietary modifications, once you have gone through the dietary and medication history, it is important that you advise the patient some dietary modifications, especially certain incriminating diets such as lactose containing products or high osmolar dietary supplements should be avoided. You should advise the patient to ingest easy to digest foods such as bananas, toast, and rice. Advise the patient to avoid alcohol because it can lead to dehydration, and avoid caffeine as it can lead to increased gastrointestinal motility, both of which can lead to a deterioration in patient with diarrhea. So also stop the medications and supplements that could be a cause of diarrhea, such as stool softeners, laxatives, and as mentioned over here. Then it is important to ask the patient to have adequate oral rehydration, which will supplement the electrolyte and sugar loss that happens because of diarrhea. Now, coming to the pharmacological management, loperamide is the drug of choice for managing uncomplicated diarrhea. It is a synthetic opioid which causes decreased secretion in the intestinal lumen, as well as decreases the motility of the intestine, whereby allowing time to increase the absorption of water in the intestine, resulting in decreased volume and frequency of stools. So the starting dose is 4 milligrams, followed by 2 milligrams to be given every 4 hours or after every unformed stool, but not to exceed 16 milligrams per day. It is important to keep assessing the patients every 12 to 24 hours, despite the patient being on an outpatient basis. And if the diarrhea persists for more than 24 hours on this dose of loperamide, you may have to increase the dose to 2 milligrams every 2 hours. And maybe start an oral antibiotic depending upon the clinical condition of the patient. Again, it is important to assess the patient every 12 to 24 hours. And if the diarrhea has not resolved after 24 hours of high dose loperamide, that is after a total period of 48 hours of loperamide, then the patient has to be again reassessed clinically as well as reevaluated with investigations. Loperamide does not work beyond this dose, and hence it needs to be stopped if it is refractory. And then the patient usually needs to be started on a second line agent such as octreotide, which is given in a dose of 100 to 150 micrograms subcutaneous 3 times a day. And the dose can be escalated depending upon the response. There are options of other second line agents as well as oral budesonide and tincture of opium. But octreotide is a treatment of choice. Most of our patients with uncomplicated diarrhea usually are well managed with dietary medication modification as well as on loperamide. Most of them don't usually require antibiotics or octreotide. Patients with complicated diarrhea, they are more sick, obviously, and they require aggressive management with hospitalization and intravenous fluid replenishment. Loperamide can be tried in these patients, but it has to be tried in the higher dose of 4 milligrams followed by 2 milligrams every 2 hourly. Octreotide is a good option. It has to be started in the same dose of 100 to 150 micrograms subcutaneous every 3 times a day, or it can also be given intravenous with dose escalations up to 500 micrograms subcutaneous 3 times a day until the diarrhea is controlled. The disadvantage is that octreotide has to be given parenterally, whereas loperamide can be given orally. So this patient, as I said, has to be should be evaluated more vigorously with a complete blood count, a biochemistry to look at the electrolyte profile, and a stool workup to rule out any infective causes by doing a fecal leukocyte, a Clostridium difficile toxin profile, and a culture to rule out the common infective organisms. There is no consensus on the appropriate role of oral antibiotics in a patient with complicated diarrhea. But if a patient has got signs of fever, neutropenia, hypotension, any peritoneal signs, or bloody diarrhea, it is recommended to start these patients on intravenous antibiotics. Patients usually respond to these measures, but there could be some patients who could be refractory and may develop chronic diarrhea. You may require additional investigations in the form of imaging, a CT scan, or at times endoscopy. CMV is a well-known cause of chronic diarrhea in patients receiving treatment for cancer therapy. And for refractory cases, empiric anti-CMV therapy with ganciclovir may be needed for selected patients who may show ulcerations on their endoscopic examination. Now, for all these targeted drugs, there are documented guidelines for managing their doses during a period of diarrhea. So you have to follow those guidelines for a given particular drug. The patients can be retreated with the same dose if they are diarrhea free and without a need for antidiarrheal agent for 48 hours. Dose reductions according to the recommended guidelines have to be done depending upon the severity and the duration for which the diarrhea was not under control. Coming to prevention, patient education forms a major backbone for preventing this diarrhea and for preventing the complications of diarrhea. The patient should be educated about the risk of diarrhea when they are started on these type of therapies. They should be instructed about the dietary restrictions as well as the medication restrictions which can cause or exacerbate this diarrhea in addition to the tablets or the drugs which they are taking. They should be aware that they need to be started on loperamide as early as possible when they have the first symptom of diarrhea. Not only that, they need to be instructed and educated that they have to be in touch and have to reassess and call back every 12 to 24 hours to assess their response and progress when they are on these oral treatments on OPD basis. They also have to be informed that if there are any danger symptoms such as fever, dizziness, abdominal cramps, nausea, vomiting, they need to immediately rush to the emergency department and may require hospitalization and intravenous therapy for their symptoms. Now coming to any pharmacological prophylaxis, we have data only for neratinib, which is a very notorious drug as far as diarrhea is concerned. Almost all patients on neratinib develop diarrhea as a side effect, and amongst them, 40% of patients had severe diarrhea. So a clinical trial was done for looking at any prophylactic agents which could prevent diarrhea in patients with neratinib. And the trial was a positive trial. And according to that, there is a recommendation that patients have to be started on prophylactic loperamide to be given at the time when you start neratinib. The initial dose is 4 milligrams 3 times a day for 2 weeks. And from 3rd to the 8th week, you can reduce the dose to twice a day. There is also a role of long-acting octreotide, that is octreotide LOR, which can be considered for secondary prophylaxis in patients who have experienced severe diarrhea as the only dose-limiting toxicity during their prior cycle. And it is important to maintain the dose intensity for better outcomes of the patient. Now, the role of other pharmacological agents as a prophylaxis, such as activated charcoal, oral alkalinization, probiotics, resicadotril, palifermin, etc., is not well documented as far as the targeted therapy is concerned for patients with cancer. So, to summarize, this is a final algorithm table which helps you to guide in the assessment and management of your patients with diarrhea. So, for complicated diarrhea, there is clear-cut indication that the patient needs to be admitted and given intravenous antibiotics and intravenous fluids. For uncomplicated diarrhea, patients can be managed on the OPD basis. But here again, you have to be prompt and you have to educate the patient that he needs to be reassessed every 12 to 24 hours to assess the response and to see whether the patient is not clinically deteriorating, and in case may require admission and hospitalization as well. So it is very important that when you start a patient on your targeted therapies, which are very highly likely to cause this distressing symptom, that the patient needs to be educated. He should be aware what are the side effects he may face and what are the actions that he has to take, and be prompt in managing that. Thank you.